We're funded by Artie's grant from NINR and our grant from the FDA REMS program. So I'm going to combine the talk that I've given on extended release opioids and with Dave Taubman's previous talk on opioid dose calculations. And my kids, believe it or not, were actually talking last night how much they love the old Looney Tunes. And so what better illustration for long-acting and short-acting opioids than Bugs Bunny and the tortoise? So we're going to talk about opioids in general, dosing, risks, side effects, about dose conversions, and then focus some specific on the long-acting opioids and what the risks and benefits are of those. So following Dave's outline, it's important a lot of people are confused by the terms of opiates versus opioids. The opiate term is just much more common, but it in fact properly applies only to derivatives of natural derived opium, which includes codeine, morphine, hydrocodone, and hydromorphone. Other very commonly used opioids, listed here, oxycodone, oxymorphone, fentanyl, methadone, buprenorphine, and tramadol, are synthetic and therefore not opiates but opioids. All of these drugs have their primary mode of action at the mu receptor. So the mu is one of four receptors. There's subtypes of the mu. But we are most focused on it because that is the receptor most centrally involved with the analgesic effect of opioids. They also mediate respiratory, euphoric, respiratory, and GI depressive aspects. The lesser well-known opioid receptors include the kappa receptor, which accounts for sedation, spinal effects. Dysphoria is kind of the most notable effect of the kappa activation, as well as suppression of antidiuretic hormone release. There's also delta receptor thought to be involved in physical dependence, euphoria, and an enhancement of the mu effect, and then opioid-like receptor 1, which has an antagonistic or anti-analgesic effect. So these receptors all interact with the endogenous opioids. Specific ones interact with specific receptors. We don't have to burden you with that right now, but that is, first we found the fact that there were specific receptors in the 70s, and then, brilliant people like Saul Snyder, who I watched give a lecture at University of Michigan completely drunk. One of the world's most brilliant neuroscientists, full professor at Johns Hopkins, he was like stumbling all over the stage. This was many years ago. Oh, not too scandalous now. I think he's either retired or dead by now. Anyway, so many features of the opioids are held in common. All of the opioids, exogenous opioid medications that are out there have analgesic effects, at least the ones that are systemically absorbed. Opioids like loperamide or Lomodal is designed to not be absorbed by the gut. All it has is a gut retardant effect. But the other ones have systemic effects, analgesia being primary among them, and a set of common and sometimes onerous side effects: nausea, constipation, itching, myoclonus, hyperalgesia, often seen in opioid toxicity, confusion or delirium we see all the time in the hospital, sedation, which is the reason why people die, and hypoventilation, as well as dependency and addiction. Nobody has ever been able to devise a opioid that is an effective analgesic that's not also potentially addictive. I mean, it's worth remembering that heroin was supposed to be a non-addictive alternative to morphine when it was first developed. So the opioids do also differ according to which receptor they interact with primarily. They differ in potency, they differ in half-life, they differ in avidity for the receptor, which is how hard do they stick to the receptor and how easily are they dislodged. There are different metabolic pathways. And because they differ in the receptor activation, the metabolism, and some are more lipophilic, some are less lipophilic. They do vary in signaling pathways. There's some genetic variations in terms of responsivity. There's some suggestion that men and women respond to some opioids differently. So it's important to mention a couple of drugs that are odd in that they try to split the difference between antidepressants and opioids. Tramadol is an SSRI, I think, maybe a small norepinephrine effect, but it is a mu agonist, a quite weak mu agonist, but nevertheless has mu effects, and as of last year was scheduled by the DEA. It had been through many years of use in Europe, and when it was first introduced into the U.S., people thought it had no abuse potential, and it was not scheduled by the DEA, but it's now a Schedule IV drug, so low rates of abuse, but I have taken care of patients, one nurse actually in particular, who was a bit of a tramadol junkie. Tapentadol is a more recently formulated mu SNRA agent, marketed as Nucynta by Janssen. It's actually been sold by Janssen. I think it got a DEA Schedule II designation and ended up, it was pretty hard to market. So it has never really developed as a very popular drug. It is more potent mu agonist than tramadol and has more mu benefits, but also mu addictive properties. So one of the more unique and interesting and useful opioids is buprenorphine. It has a couple of unique effects. It's a partial mu agonist, so it does activate the mu receptor, but it only partially activates it, so it's partly plugging up the system as well as activating the system. It seems like that would be a defect to the drug, but it in fact means that it is protective in overdose. Another feature of the drug that protects against overdose is that it slowly dissociates from the mu receptor. So buprenorphine is kind of a mu receptor hog, and it will sit on the receptor and not allow heroin or morphine to get to the receptor, so that it blocks the capacity of those other drugs when used on top of buprenorphine to overdose. It's a partial kappa antagonist. I don't know if we really know the significance of that, but some patients, at least in our hands, talk about less dysphoria when they're on buprenorphine, and they stabilize emotionally. Maybe that's why. It is a drug, although people do put it in their mouth, it's not absorbed if you swallow it, and you have to stick it under your tongue. It's the standard Suboxone form is designed to be sublingual, either in the pill or the film, and then it's also marketed as Butrans as a transdermal product. So it is useful in high-risk patients for pain control. If you're using it for opioid use disorder or addiction, you need a separate DEA certification that teaches you basic properties about buprenorphine and how to do an induction. There is use for pain, either on-label for a drug like Butrans or off-label for a drug like Suboxone. One of the big barriers to buprenorphine in this state has been that for Medicaid patients, they have to be enrolled in a state-certified addiction program to get buprenorphine, and then Medicaid will only pay for it for 6 months with a possible renewal for another 6 months. My understanding, based on a conversation I had just yesterday, is that's in active evolution, and there may be quite a bit more Medicaid availability of buprenorphine, meaning that you don't have to be in an addiction program and can prescribe buprenorphine longer term. Suboxone has come off patent, and hopefully the price will be coming down soon. There are a number of opioids that used to be popular that are no longer available, and this is basically a good thing. Meperidine or Demerol had a metabolite, normeperidine, that would produce seizures and was saccado-mimetic. Poor PO absorption, short duration of effect. was, for reasons I don't understand, really popular in ERs for a while. There are other mixed agonists like butorphanol and nalbuphine, pentazocine, also off the market. Another drug that I thought was pretty worthless was Darvon or propoxyphene. It is also off the market at this point. So just a word about equi-analgesic tables, because we use them, and I think that they are useful, but you can easily think that there's more science behind them than there really is. The point is that they are derived from single-dose studies. They're kind of amalgamated by expert opinion. They're often done in cancer patients, and for many reasons that's not very applicable to their use for chronic non-cancer pain, but it's what we have. These are some summary statements that Dave had pulled out into his slideshow. They're inconsistent and variable. I don't know if you've pulled out equi-analgesic tables from different sources. They don't agree with each other. We're supposed to use them for opioid rotation and conversion, but there's a lot of differences, both between people and within a given person according to their current health state. There are other drugs that limit the accuracy of these calculations. And the study designs are even not uniform, so that they may have been single dose, or how they handle the IV-PO conversions are also dicey. So I think the bottom line is these derived ratios are potentially really inaccurate. It's very important to be conservative when you're switching to other drugs. I would say, especially when you're switching to methadone, I would really aim way under what the equi-analgesic tables prescribe. So why are these important? Because we're constantly trying to equilibrate opioids and converting them into morphine equivalents. And to do that, we need these conversion tables. Those conversions are important because total dose is now known to be strongly related to risk of overdose and death. This is the first paper. I participated in this paper. It's based on a group health sample looking at prescribed dose relating to overdose risk. Prior to that, studies from the CDC made it look like most overdoses were due to misbehavior and not really tightly related to prescribed dose. And I think misbehavior having to do with doctor shopping or illicit drugs or diverted drugs, that still plays a role, but we now know that there's multiple studies showing relation of overdose risk to prescribed dose. From the same group, we've also been able to show that in patients over 60, fracture hazard, that is the falling and having a fracture like a hip fracture, increases particularly above 50 milligrams. One other dose-related medical risk associated with opioids is sleep apnea, prominently central sleep apnea here, which is shown, I think, in the diamonds. It's the most rapidly escalating box. But there's also the triangles showing that obstructive sleep apnea also increases with dose. And as David is prone to say, we've sent many people to our sleep clinic at Harborview on opioids, and I don't know that there's nary a one that has not come back diagnosed with sleep apnea. So it's really common in this group, particularly in people on high doses or people who take opioids with other sedatives like benzos or muscle relaxants. So I think the easiest and pretty reliable calculator is the one that the state has generated, the AMDG online calculator, and it's free, it's online, so it's one that it's easy for you to use. So now let me switch gears a bit to talk not about opioids generally, but about specifically extended release and long-acting opioids. So it's perhaps redundant, but I'll say there's only one long-acting opioid, naturally long-acting opioid. One. All the rest of these are extended release opioids. The single long-acting opioid is Medical students?
Oh, it's fine.
What's the single naturally long-acting opioid? Methadone. See? Good students. Sorry for pimping you like that. But, so the rest of these are all extended release products that have been designed to gradually release the active component out of some fancy tablet or system. There's a very specific indication, according to the FDA, for these use. Moderate to severe pain when continuous around-the-clock analgesia is needed for an extended period of time. So it's very clear that these are not intended for as-needed use, and they're not intended for short-term use or for mild or acute pain. The rationale for extended-release opioids is that they're more convenient for patients who need around-the-clock analgesia. They don't have to take pills as often. Instead of oxycodone every 4 to 6 hours, you take OxyContin every 12 hours. That, I think, is true. It is less frequent pills. However, there were a number of other rationales offered for extended-release opioids, including more stable analgesia without the roller coaster of high and low blood levels. Very similar words to this came out of my mouth. Less need to monitor pain levels by the patient and the family and the doc, so that unlike in PRN dosing, you don't have to be attending to your pain levels all the time. You can focus on your life and your function. There was also, even back as far as Bill Fordyce in the mid-'70s, was arguing that an extended or time-contingent pain medication strategy would provide less reward for pill-taking behavior, less reinforcement, and less addiction risk. So, the bad news is that to the extent that these have been addressed by studies, none of them are true. Most studies comparing long-acting and short-acting opioids have shown no difference in pain relief, either the effectiveness or the stability of pain relief or the adverse effects. Roger Chow reviewed 16 RCTs, 8 observational studies. They were unfortunately mostly of poor quality, but no advantage to the long-actings were apparent. I recently wrote an editorial for a study looking at long versus short-acting hydrocodone, and there was no difference in stability of pain intensity, breakthrough pain, sleep, depression, quality of life, or adverse events. So there is the convenience factor, but pretty much all of the other hypothesized benefits of long-acting opioids have no evidence. So Purdue Pharma, who makes OxyContin, did certainly claim that OxyContin had many benefits. Most notably, they claimed that the time-release formulation lowered the threat of abuse and addiction. And they did that quite aggressively during the period between 1995 and 2001. They were forced to pay a fine in 2007 of $634 million because they overclaimed that. It's interesting to note that this constituted a relatively small fraction of the $2.8 billion that they made off OxyContin during that period of time. And it's interesting that Purdue has been quite effective and has defeated over 400 personal injury lawsuits and 10 class action lawsuits concerning harms from OxyContin. So it is very important to orient your patients to what the risks are of these long-acting drugs if you're going to use them. I have frequently had patients tell me that, I took some extra methadone because I couldn't feel it. I used to always be able to feel my Percocet after I took it. So they need to understand that it will feel different, that they shouldn't supplement it, that it interacts with other things they may not think about it interacting with, whether it be their muscle relaxants, their anti-anxiety drugs, the beer that they like to drink before bedtime, because that's the kind of way that people are dying. So one crucial thing to be writing onto this patient counseling document is that extra doses are dangerous. I just had a patient, in fact, this week, tell me that she's been on 60 of methadone forever, and she can't really feel that it's giving her much analgesia anymore. Duh, but what she does is she cuts back on many days so that she has extra on the days when she's going to go out of the house or do something more active. She can take extra because then she does get some analgesia from it. But she was really unaware that that could be a deadly strategy depending on how much she increases her dose and what else she's taking with it. So one of the tricky things is that opioids produce tolerance. It's one reason why my patient could take 60 of methadone, whereas if I took 60 of methadone right now, you wouldn't see me tomorrow. You can really develop quite profound opioid tolerance. So there is a well-described decreased effect with repeated use or the need for an increased dose to achieve the same effect. Even trickier is the fact that different opioid effects develop tolerance at different rates. So tolerance to meiosis, or that pinpoint pupil issue, develops at a different rate than constipation, develops at a different rate than the analgesic or respiratory depression effects. So meiosis will develop, tolerance will develop to meiosis first, then constipation, then analgesic tolerance. And so even when people have become analgesic tolerant, they may not be as respiratory tolerant. So they increase their dose and stop breathing. And tolerance to understanding the sedating and respiratory depression effects is really crucial to using these drugs in a safe way. The REMS is very specific about the fact that these are most appropriately used in patients who are already opioid tolerant, so you don't want to be throwing an opioid naive patient onto these ERLA REMS. They say that's crucial, especially for fentanyl and hydromorphone, but frankly, it's a better idea for all of them to start with short actings and then go to long actings. And the REMS lists these particular criteria for people who've had to take at least 60 milligrams of oral morphine per day for a week, or 25 micrograms of fentanyl, et cetera, et cetera. That's what qualifies you as opioid tolerant according to the FDA documents. So, patients need to understand that, opioid overdose is serious, life-threatening, and really an emergency. They should call 911, not you. They shouldn't wait for you to call back in an hour or two while they're not breathing. So, urge them to call. They need to know that stuff they could have gotten away with maybe their short-acting meds, they can't do. They can't be crushing, chewing, breaking. They can't use it with other CNS depressants. Some of the ERLA opioids, and they're all changing, so I'm not sure which ones right now, dose dump. Not only does alcohol augment the respiratory depressive effects, but it can force these long-acting drugs to dump more out, leading to overdose and death. And so that's why it's important not to do extra and not to stop and start. People are generally not careful about disposing of unused or extra meds. We're trying to decrease the rate at which dentists hand out a month of oxycodone for a wisdom tooth extraction, or how safe people feel sticking their leftover Percocets into the medicine cabinet just in case they need it. Well, teenagers know that they're in there. People come through real estate open houses looking through medicine cabinets. There's a lot of these drugs getting diverted into the general community. It's very important to dispose of these. There's some confusion about what proper disposal is, with people being worried about flushing, but in fact, the FDA says these are high-risk, high-danger medications, and they do recommend flushing leftovers. That may put some oxycodone into our water supply, but probably not nearly as much as we're putting in there through urine and other kinds of excretions. So one current popular strategy of the drug companies is to formulate abuse deterrent drugs, and there's a fair bit of confusion about in what sense these are abuse deterrent. What they do is they prevent you from administering these in any way other than the usual oral route. So you can't crush it and snort it, you can't inject it, but it doesn't mean that the drugs are any less likely to produce dependence or addiction than any other drugs. You can still become addicted to the newly formulated OxyContin. Just because it's abuse deterrent doesn't mean it's addiction deterrent. It does mean it's harder to snort, although, people who use street drugs are very creative and they're constantly looking at new ways to defeat these. I think another difficulty with these is it's very difficult to decide who you should prescribe these drugs to. I think the most intuitive thing is this is a high-risk patient. I will prescribe them an abuse deterrent formulation, as if you should be prescribing any opioid to somebody who's snorting it, or who you think is snorting it. So, or actually it makes more sense to me to prescribe these drugs when somebody lives in a house full of teenagers that might steal them and use them, but I don't think that's often where an insurance company would approve the extra cost of these drugs, and these are expensive drugs with quite a bit additional cost over the non-abuse deterrent drugs. So this abuse deterrent phenomenon has always impressed me as a sideshow. I think it's just a distraction from the real important issues in opioid safety. So in summary, I think that none of the presumed advantages of early opioids have been proven. They do have increased risks of overdose, abuse, and diversion. And maybe some other strategy, like intermittent use of short-acting opioids, kind of the pendulum is swinging back. That may be the way, if you're going to use opioids, it might be a better way than using these around-the-clock opioids that back in the 90s we thought were really going to be providing significant advantages, and now we just don't think that. So here's our online training that will go over some additional material, and thank you very much.